How's your cuboid pain?
Yeah, it's good.
All
It's
right.
gone.
Guys, we've got a fourth-year podiatry student from Western Sydney Uni today, and we thought we were going to talk about plain plate neuromas. And we thought, well, why not just film it, right? Okay. Yusuf, you want to say hello?
I'm good, but
Say hi.
hello.
Introduce yourself.
My name's Yusuf from West Sydney University, fourth year podiatry.
Yep. So you only got 8 weeks left.
Yep, 4 weeks here, 4 weeks back at uni, and hopefully I'm done.
Beautiful. All right. So this is just off the cuff. So we're going to just, I don't know, talk about neuromas and plantar plate.
Sounds good.
Okay. The reason that we're going to talk about this today is because we had a lady come in and she consulted with a specialist regarding getting her neuromas excised. And she came in for a second opinion, and her presenting complaint was that she felt like she was walking on pebbles underneath the ball of her foot. And the way that she presented really didn't sound like neuroma pain whatsoever. Usually when patients come in with neuromas, normally when they kick their shoes off, they grab normally their third and fourth toes, and they'll complain that the pain is in there and it feels like it's sharp shooting, burning, tingling, electrical type of pain. She never said anything like that. Once again, it was purely pain underneath the ball of the foot. So what I've done here, we've just traced out the third and fourth metatarsals, and the way that you do that is just plain flex the toes, then you can see the med heads, and you come around like that. Once again, there's the fourth one. So if we were to, let's talk about neuromas first, and then we've got the proximal phalanges and the intermediate phalanges. Just draw them in. So the most common location to get the neuroma, once again, is between third and fourth mets. The nerve runs in between the metatarsals, and just slightly distal to the metatarsal heads, it will then start to branch out, and this branch will innervate that half of the third toe, and this branch will innervate that half of the fourth toe, and normally it will get bulbous just around there, so distal to the med heads. Sometimes they say that with a neuroma you can feel like you're walking on a pebble. It would have to be a very large neuroma to feel that. Neuromas are not hard, they're very squishy and soft, so to feel like you're walking on a pebble, the neuroma would have to be quite enlarged. The neuroma is also closer to the plantar aspect of the foot, and it is not actually getting impinged between the fourth metatarsal and the third metatarsal. It is getting impinged underneath a ligament that attaches those two metatarsals together, called the deep transverse intermetatarsal ligament. So when we perform in neuroma surgery, we make an incision in the IM space. We go down to the deep transverse intermetatarsal ligament, and then we cut it with some scissors. When we cut it with the scissors, usually you will see the bursa and the neuroma appear, and then you excise it out. So it is getting compressed with the ligament, from the ligament on top of it, rather than being impinged between the two bones. That might come out. Okay, let's give it a go. All right, so we have, this is going to be reasonably crude, but we've got, say that we've taken a cross section out of the forefoot, and we are now visualizing the med heads, and let's say 2, 3, and 4 med heads, since that's what we're discussing. Now, above the metatarsal heads, obviously we've got the extensor digitorum longus tendon, and then we've got extensor digitorum brevis right next to it. We have the joint capsule that surrounds the metatarsal heads. We have the deep transverse intermetatarsal ligament that connects those as well, and obviously they're closer to the plantar aspect. To the sides of that cross section, we would end up seeing the interossei muscles. Below the deep transverse intermetatarsal ligament, we would then have what we've been talking about, the plantar plate. All right, what else we got? Then underneath the plantar plate, we would have the tunnel where the long flexor would sit. We would have underneath that, if we took a cut, we would see the plantar fascia as well. The neurovascular bundle actually sits here. And that's what I was mentioning, that it's the deep transverse intermetatarsal ligament that's pushing on the neurovascular bundle. The neurovascular bundle doesn't actually sit in between the metatarsal heads, so it's not actually directly getting pinched by those met heads. I guess this is important, the intermetatarsal bursa. The intermetatarsal bursa would be sitting in there as well. So, and it's above the deep transverse intermetatarsal ligament. If that's interossei flexors, we would then have the lumbricals. The lumbricals would be sitting around here somewhere. And then this would also be surrounded by quite a bit of fat pad. Yeah, so that is, you can visualize hopefully the anatomy a little bit clearer. If we were to look at a side view, we would have the intermetatarsal bursa would be sitting here. We would have the deep transverse intermetatarsal ligament here, and then the neurovascular bundle would be sitting underneath. So there's just hopefully that makes sense. All right, thank you. So when this lady came in and we were assessing her pain, I'll usually start by dorsiflexing the toes until I feel the metatarsal head. And if we were to draw the metatarsal heads in, sorry Ames, and then we got, yep, so the joint's right there. And then we draw in the base of the proximal phalanges. The plantar plate pretty much obviously attaches the base of the proximal phalanx and the head and metatarsal head together. Plantar being underneath obviously, and plate because the ligament it's quite thick. So when we start palpating, there wasn't too much pain at the head of the metatarsal, but as we came to the base of the metatarsal, the base of the proximal phalanx, she started to get quite severe pain. And it was on the fourth, third, and also the second. And because these three function together, so this has an independent axis, the first one, the fifth has an independent axis, 2, 3, and 4 come together. So a lot of times you will see that you can get isolated pain or you can get all three hurting. So she started to get pain under all three. The next test is the vertical draw test, just stabilizing the metatarsal, grabbing the proximal phalanx and pulling it up and having a look at exactly how much they move. I'm not really paying too much attention to the actual movement. I just want to see if it causes any pain or not. So that's if we get a positive or a negative vertical draw test on those, and with her they all hurt. I also test the dorsal aspect of the joint, because remember it's all continuous. So you've got the dorsal joint capsule coming around to the side and then attaching eventually down to the plantar plate, so sometimes the whole joint can hurt. I've also seen where patients have got both. They've got neuroma type of symptoms and they've got plantar plate type of pain as well, or joint pain. And sometimes it's really difficult to differentiate what's the primary problem. Is it the neuroma that's the primary problem, or is it the joint pain that's the primary problem? So as a differential, I will inject a little bit of local anesthetic intra-articularly. So say that I was unsure if this was an IM3 neuroma or if it was third metatarsophalangeal joint capsulitis. Get some local anesthetic and put in about 1 ml of local anesthetic into the joint, so it doesn't go into the intermetatarsal space. It's intra-articular. Radiologically, you can send patients off for an X-ray with an ultrasound if you think there could be some type of neuroma there, or plantar plate. With the plantar plate, ultrasound is very operator dependent. Some people are just amazing at visualizing it, others don't. If the toes are doing weird things, so if the toe is coming off the ground or if it's starting to deviate, that usually means there is some form of attenuation or tear in the plantar plate, and with an ultrasound you can pick that up. But if the toe is, look at these fingers, off the ground, it usually means that there is some type of tear in the plantar plate. An ultrasound, if it comes back positive for a neuroma, I will link that to my clinical findings. If it just doesn't sound clinically like a neuroma, I ignore the ultrasound. I don't treat it. I don't treat the ultrasound. X-rays are really there to make sure that there's no underlying bony pathology. You know, who knows, there could be Freiberg's or something a little bit unusual going on. And X-rays will show that, and obviously X-rays will show the alignment of if there's something going on with the toe itself. If there's a hammertoe or claw toe forming, at least you can confirm that on X-ray as well. There's probably a few things I've forgotten there, but treatment-wise, just like all my podiatric colleagues would do, I'll do the plantar plate taping. I usually use Hyperfix. Because it's the most expensive tape and I like using good quality stuff. It's got nothing to cost. Anyway, and I'll just use 2 bits of tape. Some people use 1. I use 2 because it just tends to not strangle the toe as much. And then push the toe down and splint it like that. So it's a little bit lower than the rest. The principle being is, if you've got any type of soft tissue or ligament type of injury, if it was your elbow or your shoulder, you know, you put in a sling, you can do the same thing with the toe and bring it down. Also, if you bring the toe down, it tends to lift the metatarsal head up a little bit. You know, common complaint that they'll feel, that they'll complain about, you know, as if they're walking on a pebble, can tend to reduce a little bit. Because you're bringing the toe down, it tends to bring the metatarsal head up a little bit. I don't use domes anymore for this. I was finding that the domes were just pushing up onto that area, causing pain. Now, depending on which is hurting, I'll just cut out deflection semi-compressed felt pad. And if it's on the 3rd or the 4th or all of them, and then I will deflect the pressure away from it. So hopefully it takes away that lumpiness. And I'll get the patient to tape and pad, if necessary, up to 3 months. If they find that this is quite successful, we can make an orthotic type of device with this built into the extension, with the cutout with the extension. Interestingly, padding on the foot compared to the padding on the extension, I find that this is more effective when it's stuck on the foot, but it's not the easiest thing to do for them to keep on doing that. So that is my treatment for plantar plate. Taping, padding, a little bit of rest, a good shoe to separate the foot from the ground as much as possible, and then I will monitor. Sometimes I will do intra-articular injections of corticosteroid. I've gone off that a little bit, but I have done that. And if that fails, and it's just getting worse and worse, there are surgical procedures for it, which we're not going to go into. But what happens if it is a true neuroma and they come in and they grab those toes and they get electrical pain and things like that? It's confirmed on ultrasound, and it just marries up with what you're finding clinically. What do you do for a neuroma? I know metatarsal domes are popular. I would use a metatarsal dome rather than this type of deflective type of padding. Sometimes they like compression from taping. A wide fitting shoe to stop that type of lateral compression from occurring. When that is failing, I will inject, and you can inject a number of different fluids. Some people like corticosteroids, others like glucose, others like just plain local anesthetic. But the area that I inject is not back here, it's not behind the metatarsal heads, it is slightly distal to the metatarsal heads, because once again, that's where the nerve tends to thicken up. You can do it through guided ultrasound, or you can just go down, and once you see some blanching of the solution of the plantar aspect of the foot, just draw it up about a centimetre or so. And that's pretty much where the nerve is. It's just above the plantar fat pad. I'm going to backtrack a little bit regarding how to diagnose if it's a neuroma as well. Because my fingers are a little bit thick, even if I use the smaller finger, when you do lateral compression and you try to press into the intermetatarsal space, you know what? You're sort of getting into the intermetatarsal space, but you're also pushing on the joint capsule as well. You're pushing at on the plantar plate at the same time. It's really hard to isolate it. So with lateral compression, sometimes I'll push up and I'll see if I can reproduce the pain. Majority of the times I can't. But then I'll get my finger so you're in the metatarsal space. Now I can already feel that I'm pushing up on the third. But I'll get my finger and I'll take it from here and I'll roll it onto the third, and then I'll get it and I'll roll it onto the fourth metatarsophalangeal joints. And I'll ask them, does it feel more painful in the space or when I go over the joint? They say that it gets more painful as I go over the joint. Once again, it just sort of like indicates it's more joint rather than nerve. The Mulder's click, I don't know, maybe I just don't know how to do it properly, but this lateral squeeze and then getting the metatarsals and doing this, I rarely hear a click. I'm not even sure what's clicking, because when you excise a neuroma, once again, it's very soft and spongy, so I can't even imagine that type of tissue making a click. Maybe a squishing sound, but I don't know what's clicking. And I rarely reproduce a Mulder's click. Some people get it all the time, I don't. And I find it very difficult to reproduce neuroma pain. Once again, if I think it's a neuroma, then one of my first protocols would be to inject it with or without corticosteroids. It's usually got a long-acting local anesthetic in there to increase blood flow. You may find that if you put about 3 ml of solution in there, it's quite a bit, and it tends to also flush out a lot of gunk that's in there. So it's almost like a little bit of a washout. It calms the nerve down because of the local anesthetic. The corticosteroid may have an anti-inflammatory effect if that's put in there. If it's successful, I'll review them after about 2 weeks. If it's successful, I'll give them another one. If it's unsuccessful, I will still usually do a second injection. If I get them back and the second injection's been unsuccessful, I don't do a third one. There are different surgical procedures for it. One of the ones that I use, a minimally invasive technique, rather than excising it, is I make a little, under some local anaesthetic, just put some 2% xylocaine at the back here. I get a beaver blade and I drop it down until I hit that deep transverse intermetatarsal ligament, and then I will cut that ligament with the beaver blade. And the whole idea of that is just to decompress it. Some people do it in between, by going in between the toes, or you can do it from the top. If you're finding that your pain, it's not more plantar plate related, it's not so much neuroma, but it's actually more capsular type of pain, how could you treat that? Stage 1 type of treatment could include a rocker bottom shoe, a shoe with a little bit more of a stiff sole. They usually really like being padded up. Not padded up, strapped up. So strapping can help quite a bit, and I think it's just more of the compression feeling of the tape. If it's really bad, sometimes I'll rest them. I'll put them into a post-operative shoe or a small cam walker until it calms down, and then get them back into a shoe. If the taping and so forth are successful, they may respond to an orthotic really, really well. So we've got taping, orthotics, footwear, massage, heat, rest, stage 2 type of stuff. If it's not coming down, intra-articular injections, usually of a corticosteroid, to see if that will calm down the synovitis within the joint, and you can have a series of them over a period of time. And I will continue that for quite a good period to see if it calms down. If it doesn't calm down, then the third one would be some type of surgical procedure.